Well, hi, Dr. Geyer. So glad to have you back and to regroup with you on this really important topic of opioid stewardship. In our last podcast, we talked about the roots of the opioid epidemic and how they impacted national and societal responses, including the many state laws we saw emerge this past decade. Today, we're going to continue by talking about the key elements institutions should think about incorporating into their prescribing guidelines and considerations on how to ensure staff are educated on them. I believe we'll also be touching on the forms every opioid stewardship program should consider and think about putting in place, and a bit about the importance of referral sources. Seems like a lot to cover within one session. So let's just dive in, Dr. Geyer, and get started. And let's start by talking about the types of patient populations that you need to consider when you're developing your prescribing policies. Dr. Geyer?
Thanks, Marie. It's really good to be back with you. You're absolutely right. This is a great topic to start out with. I think if you can build out the who, and the why and the how will somehow naturally follow with that. I do want to preface the discussion with the caveat that our listening audience is likely serving a very heterogeneous patient population. I would imagine that we're speaking to a spectrum of providers and practice leaders, and this might be, kind of small mom and pop family practices, just serving very specific individuals, to those leading multi-site, multidisciplinary group practices. And with that, it's very helpful to cover some of the more basic tools and concepts that really belong in any kind of practice environment. And then from there, we can examine the other tools that could be used for more unique practice situations. So the good news is that if you treat any kind of patient, you'll inevitably be faced with the question of pain management. Data shows it's really the most ubiquitous symptom in the world, not surprising. And so I guess that brings us to our first group of patients. We'll start off with those with acute pain. As many people know, this can be due to a variety of causes, and we can look at those, trauma, specific organ dysfunction, or procedural or surgical pain, just to name a couple of them. When we think about acute pain, we really like to define that as under 4 weeks of duration, and then up to 12 weeks as being, more subacute pain. The benefit of examining the source of pain is that you can often tailor your prescribing practices to the pain indication for a much more predictable cause, in particular, both surgical and procedural pain. Now, I want to contrast this with a different kind of patient population, those with chronic pain. This is an entirely different kettle of fish, I have to say. It is a disease in itself, and the neurobiology that drives it is very different from that which drives acute pain. It's brain remodeling, it's changes in circuitry, and it really doesn't respond to the normal pain medications such as anti-inflammatories or antipyretics, even opioids, the same way that acute pain does. And so with that, it's not uncommon for acute pain to transform into chronic pain per CDC. And there's a lot of literature that supports this transition, and occurring is up to 45 days, as the number we've seen and used here at Mayo Clinic. But 3 months is the typical number we use. So really, risk stratify your patients. What kind of pain are they dealing with? When we look at those that are subdivided with chronic pain into the categories of those that are treated with chronic opioid therapy and those that are not, that helps really understand how you're going to want to manage and then develop curriculum for those groups. Individuals that are getting chronic opioid therapy for chronic pain can be very challenging to manage just because of the side effect profile, tolerance, withdrawal, dependency, those kind of reasons. And for many, it can be difficult to tell even if they transition to a state of opioid use disorder, or if they're simply struggling with ongoing undermanaged pain. I know many providers find that to be one of the most challenging topics of addressing chronic pain management. What are we actually dealing with? For instance, these patients may actually use more opioids than allotted, or seek early refills in chronic uncontrolled pain. They might visit ERs for additional pain meds or become hospitalized for flare-ups. They might prefer different versions of IVs when you've outlined to keep the pain management more so to the outpatient environment while they're seeking it inpatient. They might fail tapering efforts, or not necessarily be interested in de-escalation. And as we think about that population of those with chronic pain versus opioid use disorder, it's really important to have the right tools to distinguish. And we're going to talk about those. And then finally, the patient population that we're going to want to focus on too is those with clear opioid use disorder. These are the people that are fairly easy to distinguish in the clinical practice. They're shooting up their oral medications via IV, or they're using heroin, or The urine drug screens now show polypharmacy, or there's obvious doctor shopping. And most importantly, they meet DSM-5 criteria. You kind of get the picture. You're going to need protocols and procedures for them as well. And then to add to the complexity of this topic, Marie, we want to talk about the baseline risks of the patient themselves. Independent of what type of pain they have, the patient's going to come with their own risk factors. And you're going to need protocols for low risk patients versus high risk patients, which I would put in the group of those having underlying metabolic problems, processing problems like kidney or liver dysfunction, those with a history of severe addiction or mental illness, those with baseline cardiopulmonary problems. So to summarize all of this, you really need to take into account the patient's baseline medical issues and then the reason for pain medications as you set up your protocols and policies.
Yeah, Dr. Geyer, that is so important. And I really think a bit of what you're getting at here is also about that idea of what matters to the patient. And I know we're going to cover that later, but one example I just wanted to share with the group is related to culture and how culture impacts patients' perceptions of pain. And I had an amazing experience years ago with my dad, who's from Ireland and, a tough guy who just doesn't have pain. And he fell off a ladder into a basement one time. And he's a skinny guy. You could see the hematoma. He was in, and when I asked him, I said, Dad, how's your pain? He said he didn't have any pain. And I was so confused by that because you knew he had pain. And in his mind, he was sore. But he didn't have pain. So it just taught me a long time ago as a nurse to be really conscious of the cultural impact of pain as well. So I think getting to your populations and really understanding the acute pain versus the chronic pain and those kinds of things, and also thinking about somebody's culture might have an impact on what they think of as pain is something that we all really need to pay attention to. So thank you for that, Dr. Geyer. And I know this is such a challenge for those out in the field trying to deal with this every day, but I know that our listeners are up for it and really want to learn so they can do this best. So let's talk a little bit more about the basic and standard policies that medical centers need to consider addressing when it comes to opioid stewardship. You mentioned acute pain as being likely the most common indication to be encountered. Can you share a little bit about what providers should have in place before prescribing for this reason?
Absolutely, Marie. And in tandem to the concepts you brought up just a second ago as well, you're right on. The perception of pain really hasn't changed, if not worsened over the past few years. We would think with all of the medications and non-interventional and interventional procedures that we have out there, that we would have a tremendous decrease in the pain in America. And what we've seen is that chronic pain is actually increasing. We haven't made a lot of dent, and cultural impact on that is tremendous. So great to point that out. This is one of the reasons that it's important to have policies and procedures, because we know pain is going to be there. Many of us probably wouldn't hit the freeway without our seatbelt in place. It's really our insurance policy, shall we say, that even in the event of a catastrophe, we're minimizing these negative impacts on ourselves. And that's what these guidelines offer. So if we were to start off on acute prescribing guidelines, if we look at the concerns of why we have these in place, there's a reason for it. We recognize that somewhere between 8 to 12%, and I saw as high as 19% in a recent study, of individuals that are started on an opioid will ultimately develop opioid dependency or opioid use disorder. That's not a small number, Marie. Longer lengths of treatment, typically more than 3 days, higher doses, higher potency, higher use of refills, and courses that are for the wrong indication are all going to increase these risks. And then keep in mind that the patients are going to come with their own risk factors, like we talked about, the cardiopulmonary problems or family or personal histories of addiction or mental health disorders. So you're going to want to mitigate these risks to the best of your ability, and policies are going to help with that. The CDC and a number of clinical trials have really shown us what you want to have in place when you start providing these practice policies. First thing I would think about is what you going to want in place before that prescription, that first prescription, is ever written. And I would start off with the following elements. First off, a review of those patients' risk factors for opioid use disorder and overdose. They are two separate entities. Keep that in mind. Many providers have been using the opioid risk tool or the ORT. Keep in mind that's been primarily validated in chronic prescribing environments. So the numeric score that comes out of that may not necessarily be as applicable as people deem it to be. But the elements that go into that, the age, the gender, the mental health disorders, the history of addiction, and other elements are all things that are very helpful to help guide your practice and think about the risk factors in that patient. The next thing you're going to want to do is look at the patient's medications. You're going to want to look for what is there and what isn't there. You're going to want to avoid co prescribing opioids with other medications that increase risk for overdose. And the data shows that benzodiazepines, muscle relaxants, sleepers, other sedatives are all going to increase that risk. You're also going to want to make sure that you're maximizing non opioid treatments. If it's not already on their medication regimen, consider adding scheduled Tylenol or NSAIDs if there's not a direct contraindication. And don't forget topical agents for many conditions, especially arthritis. They can have great efficacy. And next, you're probably going to want to make sure that you have a physical exam on board before ever prescribing that opioid, at least the first time. It's not best practice, but in many states, such as ours here in Arizona, it's also the law. I recommend repeating this for patients that are not responding to treatment as expected either, especially before providing a refill. Look in the exam, not just to justify the cause of pain, but also look for other features that might suggest that this person's at high risk for cardiopulmonary or liver related complications. You can pick up a lot on that exam. Other things you're going to want, make sure you have that PDMP or prescription drug monitoring program reviewed. Many states, if not most, will have a law in place regarding this. It's going to be a requirement, but I would build it into institutional policy as well, just to be safe. And then make sure that you have documentation policies. Your next coworker may have no clue how to manage your patient if you don't have it well documented. And that includes putting in your concerns, what you did see, what you didn't see, and what were some patient behaviors that would be important to include in the next assessment. If, of course, a patient is deemed higher risk, this is your opportunity to provide justification why you did or did not feel comfortable prescribing opioids if something were to ever head south in terms of that patient's case. And then it's a good opportunity to offer Narcan in those situations. I'm a big fan of offering Narcan in every situation. Most states allow you to offer Narcan, and it's good for patients as well as families and friends to have it on hand in the event of the worst case scenario. So these are just a lot of the more common things I would think about, Marie, as we start with acute prescribing guidelines. Again, CDC has them embedded along with many clinical studies as a body of evidence to support them.
Dr. Geyer, that's great. I think that as we look at what some people have called the gray tsunami that's coming, right? The aging of the population and the numbers of folks 65 and older. We have a social movement called Age Friendly Health Systems that we work on, and it's based on the 4 M's: what matters, medication, mentation, and mobility, and looking at those things together. That so much of this is so important to that population, not only, but really gets to people and what tolerance do they have for pain? How do they describe it, as we talked about earlier? And then what do they want to be able to do in life? I'm 61, and one of the things that's really come into my mind as I get to this point in life is, what do I really want to be able to do in my life going forward? And that is, I want to be able to be active. And so I think about, those little twinges that you have, that little issue in my back, and what are the things that I'm going to do? And you mentioned topical agents and things like, I know that things like acupuncture. And so I've really learned to use those things in order to manage pain, in order to be able to keep doing the things I want to do. I'm not going to, be a CrossFit champion, but I want to be able to do some lifting and do some walking and do those things in order to stay well and stay healthy. So getting to that issue of what matters to someone around pain as well seems so important. And our culture is getting more open to the kinds of non-traditional pain management that we have access to. And I love the blending of sort of the East and Western medicine worlds in order to be able to provide those things for people. Any thoughts about the aging going forward, and pain control and pain management is, I guess, a better way to phrase that?
Oh, you've summarized some great points there, Marie. Every time we prescribe a medication, the first question we should ask as providers is, what are we doing to you? And is it of enough benefit that it justifies what we're doing for you? it's not necessarily in the interest of the best or the best interest of the patient. And that's why it's important to have those discussions. I'm so excited because the new CDC guidelines, as an update from those of the 2016 guidelines for chronic opioid prescribing, should be available fairly soon. I've been able to have a sneak peek of some of the elements in there, and especially the evidence base that supports or refutes the use of many of these other adjunctive non opioid regimens. And there's some great evidence out there for use of them. And so I encourage our providers, as soon as those are released, to integrate them into their practice because I think it'll be really helpful to avoid opioids and improve quality of life.
That's fabulous. I love to hear that, Dr. Geyer, because it seems a successful strategy for me so far. And not that I'm trying to be selfish here, but I try to learn personally from everything you say, Dr. Geyer. So I'm glad to hear I'm on the right track anyway. So this is all very helpful. We have some proactive ways to avoid running into complications before the prescription is written. How about sharing a bit around what policies should be in place when it comes to actually writing the prescription?
Yeah, that's a great topic, Marie. So what we've talked about are all the before you prescribe policy recommendations, but you're going to need some when you prescribe policy recommendations too. And I would recommend everybody consider the following when we do this. First thing you're going to want to do, set limits to the amount of opioids a provider can prescribe per indication or per broad grouping of indications when appropriate. This could be as generic as saying, okay, for acute and non surgical pain, our standard practice approach is to provide a maximum of, say, 3 days duration. And for acute surgical pain, for a maximum of 7 days. We had done some internal benchmarking here at Mayo Clinic for surgical indications, and we found out that 2/3 of all prescriptions that we wrote for opioids were sitting in a patient's medicine cabinet on average after we offered that. It was based on that we were able to scale back and really re-change our practice to make sure we were giving more of a limited provision to match what's necessary for the patient, keep them satisfied, and still not let a lot of these meds go unused in medicine cabinets where they become risks to other people. I would say if a practice is subspecialized, orthopedic surgery, consider creating a list of standard prescribing practices by procedure, such as total knees versus hips. Get a better understanding of what the literature supports for those populations. And keep in mind, your state may already have prescribing limitations in place. Some states use the total number of days, some use total number of pills, other use morphine mill equivalents. If your state doesn't have standards in place, feel free to refer to the 2016 CDC guidelines. They do have some supportive evidence in there on what to use and not to use. And again, those will be updated soon. I have to tell you, as a hospitalist, having these institutional requirements to lean back on has been a lifesaver for me in a lot of situations. There are some patients that are very particular about the regimen or how many pills they get, how many pills they've been getting. That guides the conversation to where they want it to go, not necessarily what's in their best interest from a safety standpoint. And so having this policy helps me rely back on the institution, back on evidence base, back on the state to provide my argument as to why I've offered what I've offered. I think it provides the provider some morale and efficiency in the process and gives the patient more of an understanding of why the practice has changed. I would also recommend developing refill and opioid change policies. These are key. For refills, consider addressing not just whether you'll offer refills, but what else needs to be in place before you even do it. Do your patients need to see the provider again in person? Should refills always follow the original provider, or can colleagues cover? How many refills are you going to offer? As for opioid changes, it's funny how these are often requested at about 4:59 p.m. when your workday ends at 5. I would have a policy in place to rely on if your hydrocodone that's worked for most patients with this condition is not cutting it for Mr. John Doe. Are you going to be willing to escalate it to oxycodone for him? What's the plan? How about changing the dosing frequency? If someone calls in and they want to take it every 4 hours as to every 6, what's your policy? I would say my general recommendation on this topic is to approach it cautiously. If the patient is opioid naive and your pain regimen has worked historically for most patients with this disorder or this complaint, consider looking for complications. And if complications aren't very likely, maybe consider shooting for optimizing adjunctive regimens before just up titrating the potency or the dose of the medicine you're using. You're also going to want a Narcan prescription policy. Remember, populations that benefit from Narcan are primarily those with a history of opioid use disorder or if they have baseline cardiopulmonary problems, kidney conditions, a personal history of substance abuse. The data shows if they're on more than 50 morphine milliequivalents per day, that can be high risk too. I'm a big fan, like I mentioned, to giving it out to everybody, but for those populations I've just mentioned, it's especially key. Also consider doing it for anyone receiving chronic opioid therapy or more than 90 days of treatment. And then finally, you're going to want some basic office policies that are going to keep your practice flowing smoothly. Some good examples. Does your practice engage in opioid prescribing on a chronic basis anyway? And if not, what's your list of referrals for patients that might need that? Do you send everyone out to pain management? Do you have those referrals ready to go? Will you be providing opioids or refills over a weekend? Do you have patient harassment policies if your care team is being treated on a more hostile relationship basis? Having these responses ready to go could save you a little bit of energy as opposed to developing them in real time. So all of these put together, I think, should be in place for every medical practice that offers opioids.
Yeah, that communication piece is so critical, Dr. Geyer. I can, remember situations where physician may be covering a partner or another physician over a weekend, and communicating about those patients who have some of these situations going on can be so important, because as you said, either at 4:59 or right over the weekend when that patient is distressed and needs help with their pain, and if the other covering physician isn't aware, it can really cause a lot of difficulty for that patient. So I think that's a really important point, as well as making sure that the office staff is supported and has policies and procedures in place that support them as well, because they're frequently the front line on that and receiving the concern from the patient or from the patient's family. That can also be another piece of that.
Absolutely.
I have one question, Dr. Geyer, about Narcan. I know you did an amazing blog for us on Narcan and the importance of it in the field. Is there a practice of prescribing the Narcan for the patient to carry? Those of us that have allergies or things like that, we're, encouraged to carry EpiPens and things like that. But I just wonder, whether that's something. I realize the patient might not be able to use it, but if somebody came upon them and was familiar, would they be able to use that Narcan? Just wondering about that.
Yeah, you're raising a very valid question. I see a number of individuals that prescribe opioids to their patients and don't necessarily highlight the value of keeping Narcan on them and training their family members about how to use it. Keep in mind, the average individual who is undergoing an overdose or experiencing it, I should say, isn't necessarily going to be providing their own medical care during this process
That's right.
to resuscitate. And so that's why friends and family education is absolutely key. I encourage patients that are going to be placed on Narcan to bring a family member to the appointment so that Narcan can be taught to that individual. You can go online. YouTube videos are there left and right teaching you how to use it. And there's so many different formularies out there, not necessarily just injectable, but intranasal sprays and other versions that make this very easy to use. I've seen some populations go as far as getting medical alert bracelets that they're receiving chronic opioid therapy. And that can be very useful, especially for emergency services if someone's found down and we're looking for a cause to just try empiric Narcan if the situation would fit. So you're right. Keeping it on hand, keeping it close, and keeping people educated on how to use it is so helpful.
I love that idea of the medical alert bracelet. I think it really gets to helping combat the some of the stereotypical kinds of thoughts people have about this, and really grounding this in the medical condition and in the way that we think about treating that. To me, that should be like a best practice, that we really think about that. Of course, as long as the patient is interested in doing it as well. Well, I think that you've made such a great point about prevention is well worth a pound of cure, if I want to use a frequently used statement. The recommendations are really in line with something the AHA worked on previously, which was Stem the Tide, our opioid stewardship principles. And that's been out now for some time. We developed it a few years ago. It's been updated, but really something people have responded positively to. But can you talk a little bit now about prescribing in the setting of chronic pain? You mentioned that that's an entirely different kettle of fish. So I'm curious to see How screening and monitoring differ from those acute pain settings that we've talked about?
We talked about buckling our seatbelt when we did acute prescribing to make sure there weren't complications. And when we do chronic prescribing, we're going to upgrade these seatbelts and we're going to put on lane change assist and auto braking and hazard lights and one of those cute little stickers that says baby on board. To put it bluntly, this can be a high risk practice. And so you're going to want to take every precaution. When we think about chronic opioid prescribing, we have to think about what's going on in the brain. What has changed from acute prescribing and what sets the body up for opioid related complications that's so different from acute prescribing? The chronic use of opioids really fundamentally restructures the brain and changes all these neural connections. Areas of the brain that connected different sections to other sections through neurotransmitters were previously dirt roads in many situations, and we're turning them into 4-lane freeways when we do chronic opioid prescribing. This restructuring ends up being kind of the major cause for opioid use disorder and also sets up the higher risks of respiratory related complications that can lead to overdose. So, for this reason, you're going to want to add some extra layers into your standard practice. The first thing I would say, number one, screen, screen, screen. Who is appropriate? Beyond the standard pre-screening that goes into just acute prescribing, you want to look closely and evaluate whether or not the condition that your patient has is really well known for responding positively to a chronic opioid therapy. Is this even going to work? If your patient has chronic headaches or fibromyalgia or one of the other myriad of conditions that's been shown in literature not to respond well to opioids, look elsewhere. Keep in mind that in general, there's a paucity of data on the benefit of chronic opioid prescribing outside of cancer or palliative indications. And so we try not to chronically prescribe opioids for chronic pain. There are certain indications and certain situations where patients find it very beneficial. They respond appropriately, they're more functional, they're not overusing or inappropriately using the medications. You want to individualize your care. But as we talk in more generics, more general terms, you're going to want to look for non opioid therapies for this grouping. Something else, always, always, always make sure that you have policies that require integrative therapies, non pharmacologic therapies, non opioid treatments. There's actually some great evidence emerging on the value of incorporating, just like you mentioned, Marie, PT, OT, massage therapy, topical agents, mind body therapies. Putting all these together, the same things with mental health treatments, patients can have a lot of benefit. There's, like I mentioned, so much overlap between chronic pain and depression, and the care team approach to pain management with counseling might be very beneficial. I personally found that patients that are engaged with more of a mind body approach to chronic pain are more engaged in their care and they're more hopeful, they're more active. As for medications, medications that are targeting the neurochemical abnormalities that can be associated with chronic pain are also going to be key. Antidepressants have some pretty good data. In some situations, gabapentin and pregabalin can be helpful as well. And then, of course, never, never forget the role of interventional procedures. There's a host of them out there, and some of them I can't even pronounce these days. They're emerging so quickly. Many of these selectively target the source of pain as opposed to just drugging the whole body. And so you're doing the patient a favor if you can really go after source control. And then I would say after this, you're going to want policies and procedures that really up your game on screening. This is where the opioid risk tool or the ORT becomes essential, and providers can use this just by Googling that phrase. I would recommend using it at every single follow up visit, which for chronic pain should be at probably a minimum of every 3 months. You're going to want to make sure that the risks in patients for opioid use disorder haven't changed. Also, I would consider incorporating more comprehensive screening for other associated mental health conditions. At Mayo Clinic, we use the GAD-7 and the PHQ-9 looking for anxiety and for depression because those can be chronically associated with chronic opioid use and chronic pain. We repeat those at least annually, but you could do it more frequently if you needed to. And then, of course, you're going to want to monitor your primary outcome. This is functionality. Keep in mind that treatment of chronic pain is a mindset change. The goal is never, never, never elimination of pain. If they get that in the process, fantastic, but it is not the goal. Patient functionality is the goal. And so we use the PEG tool, again, which can be easily accessed online, which is a validated resource to administer at each follow-up to determine just how functional they are. Consider pairing these with other things, urine drug screens, pill counts, at least on an annual basis, if not more frequent, and certainly tailor these to the timelines and the risks of the patient. And, finally, I would say once you've decided that the patient is really an appropriate candidate for that opioid therapy on a chronic basis, you're going to want to have the talk. Everybody knows what the talk is, right? And that's that risk benefit discussion that many states now require in law to take place before you initiate chronic opioid therapy. I recommend considering developing a chronic opioid therapy agreement or a COTA. And on this document, you're going to want to put the risks of taking the opioids there, the side effects, things like tolerance and withdrawal that can be affected, and then all office policies on there. So that's going to be things like your refill policies and timelines and follow up requirements, any agreements for the patient to participate in multimodal therapy and be screened, such as urine drug screens or pill counts, what you'll do if there's doctor shopping identified. The benefit of this is that if you have an opioid contract on the patient's chart, that's really going to be helpful for other providers to know, hey, I shouldn't be prescribing opioids to this patient if they have a fair amount of supplies at home, or if they have this agreement on board and me prescribing would violate that. I would also put on there exactly what next steps are if that patient breaches their document. And this, Marie, I think is a key topic that we don't want to miss. What do you do when your patient is breaching that contract? It's going to happen inevitably in your practice if you're using these controlled substance agreements. Every breach, I believe, requires a sit-down session with that patient to discuss the why behind the behavior. Sometimes there's shockingly legit excuses. Not every patient, but some patients. And if the pattern of behavior looks more like opioid use disorder, again, use DSM-5 screening criteria and refer out as appropriate. These people need help. If your office is capable of prescribing buprenorphine, fantastic, if that patient truly has the condition. And if not, it may sound counterintuitive, but don't immediately stop prescribing opioids if there is a breaching contract, including if that patient might have opioid use disorder. The goal is to get them to treatment for opioid use disorder as soon as possible. And if that requires a couple extra days to buy them over until they enter that treatment program, it's worth doing. We're seeing a huge increase in individuals that no longer receive their treatments, their opioids through their primary providers, that are now hitting the streets to receive that therapy. Keep in mind, 90% of people that are not started on MAT, or medication-assisted treatment, or also known as MOUD, medication for opioid use disorder, that's buprenorphine, that's methadone, that's naltrexone, will relapse within a year, even if other treatments are integrated. So make sure that you are an associated bridge to getting that patient help. I think that the only time I would recommend not providing some kind of a bridge to get them to treatment is if there's clear risk of diversion. It's illegal, it's very unsafe, and it's not something you at all want to be complicit in. The last thing I'd say, Maria, you're going to want your providers to consistently review when to taper at every visit. Build a policy on it. If you're seeing these people every 3 months, after the first 4 weeks of therapy, as soon as that, if you're not seeing functional improvements in your patients, or if the dose needs to be titrated upwards, there's a good chance this is not a condition that's going to respond to chronic opioid therapy, and it's time to start tapering, time to think about other therapies. Make sure that you've got that list of referral options on hand as well. This is to chronic pain management, to opioid use disorder treatments. Practices want these lists available for all providers. And so I would start building relationships, and sometimes social work can be very helpful in establishing those.
That's so important. I think the idea of, not pulling the rug out from under patients who are struggling with these issues and making sure they've got the support and the resources and focusing on treatment rather than just ending something so important to that what matters and what's important to that patient's health and well-being. So thank you for pointing that out. Really, really appreciate that. So I'm going to move now. We have covered an amazing amount of information and just so much territory in this talk today. But the one thing I want to just pull us to is, how do providers keep track of all this? We've talked several times about communication and, being able to pass the information from one provider to the next. Our electronic health record is certainly something, or the medical record in other cases is certainly a vehicle that we use for communication. Do you have any insight or thoughts or recommendations on how to really use that vehicle to keep all of this information in order and be able to share and communicate from provider to provider?
Excellent question. Marie, a simple phrase: work smarter, not harder. And the smarter, less harder approach to this is going to be utilizing the electronic medical record. I can't imagine doing this on paper in most practices. Keeping track of who's on what, when they need to be seen, how you're going to communicate with the next provider is almost an impossibility unless you do that. So IT can be your best friends on this topic. At Mayo Clinic, we use Epic. We've had the ability to create something called an opioid action plan. And this has been a great tool where it keeps everything in place for the patient. It flags the chart for other providers to recognize that this patient has a controlled substance agreement on the chart. That'll be a good reminder, like I mentioned, for others not to prescribe opioids without notifying the original prescriber or without having that conversation. It also allows the provider to set alerts as to when something needs to be completed on that patient with chronic therapy. That includes follow-up visits or a urine drug screen, things like that. There's also a very specific area in our chart to document encounters and concerns that we've had with patient behaviors on this topic. I've found the tool so useful, Marie, and although, a bit difficult to integrate in standard practice without building it, it is worth the upfront effort. So have that conversation with IT and petition leadership at your institution for support to build it.
Great advice, Dr. Geyer. Absolutely. And certainly, I would think at some point, if folks wanted to connect with you a little bit about that Epic build, I don't want to put words in your mouth, but I'm thinking you would be willing to have that conversation at some point. We'd be happy to facilitate if that's something that folks would be interested in.
More than willing, Marie.
Thank you. So we have covered an amazing amount of information today. I am sure that our audience will find it very helpful. I learn so much from you every time we do one of these podcasts. So thank you, Dr. Geyer. I hope that everyone can join us for our next podcast, which will be our final podcast in the series, where we'll discuss the prescribing metrics that you're going to want to look at and follow to prepare your patient population for impending changes in opioid stewardship. We really look forward to chatting again, Dr. Geyer, and for sharing the amazing information on this important topic to our country. So thank you so much for your time today. And Dr. Geyer, we very much appreciate yours as well.
Thank you, Marie. Honored to be with you.